as I said, my name's Claire. I'm a consultant gynaecologist in Glasgow. As you can hear, I'm from Northern Ireland. And just to add a wee bit more confusion, I did my subspecialty training in gynaecology in Dublin, and this piece of work is actually from my time as my year as a first year consultant at St James's Hospital in Trinity. Thank you for the opportunity to speak today. Compared to a lot of the other great presentations I heard, I feel this might be a bit basic, but I hope it comes across okay. Medicine's a journey. It's a journey I wouldn't change for the world, and we all start to begin somewhere, and we all start as a medical student on day one. And even now, when I look at medical students on day one, this is what I see. They're bright-eyed, they're bushy-tailed, they're fluffy wee sponges ready to take off everything that we throw at them, and they're just adorable. 5 years later, they look like the cat that's got the cream, and they're absolutely justified because they've got through training, which is still very challenging, and they've done extremely well to get through and pass. And then they are going out, skipping, excited, ready for day one in work, and they look like this. And they come down to earth with a huge bump, just like I did when I was a JHO, and ironically 18 months ago felt exactly the same when I became a consultant. So the journey continues, but this is the part of the journey that this project wanted to look at. Because the transition from medical student to doctor is still very, very difficult, and many undergraduate curricula still often lack content what is directly applicable to clinical practice. And due to the need to include so much more in undergraduate training now, we've actually cut down a lot of the apprenticeship time that students used to get. But the job hasn't changed. JHO, intern, FY1, whatever term you use, it's still an extraordinary job where you're a glorified secretary between 9 and 5, and then after hours and during the night you are responsible for seeing every sick patient in the hospital as the first person. And a lot of people are feeling just not as prepared as what they would like to be, and that's what's resulting in a lot of personal and professional stress. I have no financial interest in this book, I swear, but if you haven't already and you do get a chance, it's worth a read. The medical students I worked with, they love this lad, and when you ask them what they think about the book, they all say it's hilarious, it's awesome, it's brilliant. I am reliably informed by younger people that the word sick is now used to describe things that are really good, and they all think it's absolutely brilliant. And then I turn around to them and say, well, actually it's the saddest book I think I've ever read, because Adam Kay was actually a very, very good doctor in obs and gynae, but it just got too much and he left. And that's not a spoiler, you find that out in the first page, but it is extremely sad. And it's extremely real in that people are feeling much less prepared, critical care training is often suboptimal, and students are really starting to feel it. And mental health is now reported as 30% across the medical student population, which is just scary. And they're having an increase in stress upon coming into clinical practice. Why do I care as a gynaecologist is because this is now at my doorstep as well, in that the RCOG had to pull out the scary figures over a year ago that a quarter, 25% of our junior doctors feel like leaving their job every single week, and 30% of our trainees don't finish. Our attrition rate is 30%, and that is just getting to the point that it's terrifying. Now this is multifactorial, I don't doubt that for a second, and the colleges are doing so much more now to help other factors such as getting rid of bullying and undermining and so on. But from a personal point of view, whenever I'm on the ward, and in gynaecology our ladies can get very sick post-operatively, and when you see the stress and the fear that is in trainees now when they go up to see this woman and try to figure out what's wrong and try to support her, that's where I think we need to improve as well. Simulation in critical care is old hat. It's been well recognised to improve performance at postgraduate level, and thankfully there is now an increase in focus at undergraduate level, and including the importance of training in communication and teamwork. I wanted to find out where we were in Trinity whenever I started the work there, and I did a survey of 100 fourth-year medical students, and I assessed their current confidence in undergraduate training and their exposure to critical care and simulation, and then broke that down into what their confidence was at each step of ABCDE, and also about teamwork and communication. I felt a wee bit sick when I saw this. 7%, 7 out of 100 students felt confident that current training would prepare them for life as a junior doctor. 56% admittedly just didn't know yet, but what's worrying is that well over a third were unconfident or very unconfident that they were going to be ready. Now, whenever you ask them had they seen a critically ill patient and we give them the definition of this, about a third had, but about over half hadn't, and a wee bit worrying was that 18%, even with the definition, weren't entirely sure. So recognising the sick patient is also a worry. Like all universities, Trinity are improving their simulation, and 93% of our fourth years had already had exposure, largely due to the SimMan training for BLS that you have in third year, which was great. But the thing that I latched on to was that 66% of our students still felt unconfident or uncertain that they even had a system to go through A, B, C, D, E. So not that they were going to figure out what was wrong, not that they were going to have all the answers, but just they hadn't even got a system to do it. And that was what we looked on. So in the academic year of 2018 to 19, I designed a new 2-hour tutorial which gave a 1-hour lecture on a system to assess A, B, C, D, E. And it used AIR, and AIR is where you assess, you intervene and you review at each step before you move on. And I gave them an approach to recognise that there was something wrong and that they needed to do something and check that it had worked. And then we did simulation with cases for an hour as well. This is kind of the makeup I give the students to try and simplify it as best I can, and how they need to do that at each stage where they assess, intervene and review. So we had case scenarios, so they were a moulage design very similar to the SimWars here, which I think are amazing. There's 68 students working as a team. They have a simulated patient, which was usually a member of staff or sometimes a nurse, and equipment was usually what I stole or borrowed from the wards. And I also found Simple, which is an app that you can download for free, and you can put it on your mobile phone and link it up to your laptop, and you can change the observations depending on how the students are getting on. And that's how we worked our simulation, so cheap and cheerful. But the students seemed to love it, and the positive feedback was what we found very, very pleasing, and especially when people were saying the interest to educate us for beyond medical school was greatly appreciated. And so we decided we wanted to measure exactly what we were doing. So we did an observational study which assessed the student performance both before and after the teaching session. We got ethics approval, and we invited the last rotation of the year to participate, and 27 of the 50 students enrolled, and it was completely voluntary. They completed their surveys both before and after, and then they did 2 OSCE stations. One was in the first week of the rotation before the training, and then the second was at the last week of the rotation after they had all went through it. We did 2 case scenarios. The first was a ruptured ectopic pregnancy, so the management of bleeding and hemorrhage, and then the second was on sepsis. We designed the proformas based on AIR and also had a global assessment score. Now, I appreciate the numbers were small, so for our statistical analysis we did a 2-tailed t-test using SPSS. So in terms of our results, so remembering where we were, so we were at 66% felt unconfident or uncertain that they had a system to perform ABCDE. And this is where we got to. So we had now 96% that felt confident or very confident that at least they had a system in which to work from. When you broke that down then to the different steps, so starting at airway at the bottom and going up to communication and teamwork, at the start you can see a lot of yellow there for unconfidence and extremely unconfident in purple, especially when it came actually to teamwork and things like disability, so the rarer stuff. This is then where we move to after the training. So it's not red across the board, it's not very confident, I wasn't expecting that, but just to get that shift out of the really unconfident scores was what we wanted. And you can see we made that move. When we applied this statistically, we did get a significant improvement in all areas using our P-scores, and 100% of our students were requesting more simulation in the undergraduate curriculum. When we went then to the OSCEs, 25 out of 27 students completed the OSCEs. There was 2 students that genuinely couldn't make it on the day. They actually came and did the OSCEs afterwards by their request, but I didn't include them in the results. 88% achieved a higher score on the second OSCE, and 88% improved their global assessment, 8% remained on stable scores. And a very busy slide, but just so you can get a visual appreciation, the red numbers column was all the guys that improved, and the green was where we improved their global assessments as well. And again, when we put this into the old SPSS, we got it to statistical significance for both the OSCE and the global assessment scores. So in conclusion, we therefore recommend the early integration of critical care simulation in undergraduate training. I personally feel that we should be bringing this in at the end of third year and certainly in fourth year. These students are really hungry for this and they want it. And it does not have to be highbrow, it doesn't have to be all singing, all dancing. This is very cheap and cheerful what we did. But through what we did, we got an outcome that was positive, that we measured. And more importantly to me, we got an outcome the students actually felt. They felt more confident at the end of this. And Trinity are hopefully taking this further forward with the aim that whenever these students now come to finishing their training, they will be able to protect their patients more, they'll be able to protect themselves more. And the hope is that they actually then go on to have very fulfilling and long careers. I had a lot of help, especially on the OSCE days, and I'd like to thank everybody that was involved, and also especially the students. And thank you.
Thank you very much.